What's up? Time Talks Med here. I've now simplified all the most important high-yield topics in heart physiology. So this is the complete cheat code for heart physiology. We're doing this in 4 segments. This is the first video where we're going to talk detailed about the different types of cardiac muscle, the action potentials of pacemaker cells and contractile myocardium, and the general properties of our cardiomyocytes. The second video will be about the cardiac cycle. The third video, we will cover everything you need to know regarding the cardiac output. And in the fourth video, we will cover the regulation of the heartbeat, covering all the most important mechanisms that actually changes the contractility and the heart rate. Alright, awesome. Alright, so I'm starting this video assuming that you already have a pre-knowledge in the anatomy of the heart. I'm basically assuming that you already know that the heart has 4 chambers, you know that the heart has 3 layers, the endocardium, myocardium, and the epicardium. I'm basically assuming that you know that the heart is an organ in your chest. If you know that, you're good. Let's continue. Now, the topic about the heart muscle falls under electrophysiology. This is an extremely important topic, and the reason why it's important is because the heart is so special. It has the intrinsic ability to spontaneously depolarize itself and cause the heart muscle to contract. We will cover in the 4th video how the nervous system, like the extrinsic innervation of the heart, can speed up the heart rate or decrease the heart rate, as well as maybe increase the contractility. But again, I want you to understand something about the heart, is that the heart exhibits something called automaticity. So it's able to depolarize itself continuously without external stimulation. How is it able to do that? Follow along, and I will ask you that question again at the end of this video so that you can answer it without hesitation. In theory, we can classify cardiomyocytes into 3 primary functional categories based on their general role in the cardiac physiology. So in this area, we can divide the muscle cells into 3 functional categories. First one being pacemaker cells, we got contractile cells, and the last one, many don't consider it as a classification on its own, but the heart also exhibits some endocrine function as well. So these are the 3 main muscle cells with their own primary function within the heart. Now, pacemaker cells. Pacemaker cells are cells located within the conductive system of the heart. So we can also call them nodal cells or non-contractile cells. These are the ones that generate automaticity. So these are the ones that can spontaneously depolarize, generate an action potential. Alright, now where can you find these pacemaker cells? If you look here, the main node that make up our normal rhythm is found in the superior lateral border of the right atrium, called the SA node, just beneath the superior vena cava. The SA node is the main pacemaker. It sets the pace. When it generates an impulse, it will send impulses towards the left atrium through the interatrial bundle, aka Bachmann's bundle, and it will send impulses down through the internodal pathway towards the AV node. These pathways are just fast conducting pathways so that the signals reach the contractile myocardium faster. Now the AV node is really interesting because look where it's located. It's located at the junction between the atria and the ventricles, just behind the tricuspid valve at the beginning of the interventricular septum. So it acts as a gateway for the impulses passing from the atria to the ventricles. After the AV node, impulses are then sent down the ventricular septum as a bundle of His, which continues on as the right bundle branch and the left bundle branch. Then from there, the impulses are further conducted towards these braking units called Purkinje fibers. Now, these pacemaker cells are all special in their own way. So the SA node primarily consists of pacemaker cells that are specialized for generating spontaneous action potentials. So they have a fewer contractile fibers and more ion channels. So we say it's the natural and primary pacemaker, which generates sinus rhythm of around 60 to 80 beats per minute. Sometimes, if the SA node is damaged or if the electrical conductive system of the heart has problems, then the secondary pacemaker, which is the AV node, sets the pace. If the AV node takes over, it usually generates a slower heart rate, around 40 to 60 beats per minute. If the pacemaker cells in the AV node fails, there are theoretically some pacemaker cells within the AV bundle as well, or the bundle of His, denoted as the tertiary pacemaker. Purkinje fibers, again, their job is to conduct the impulses towards the ventricular contractile myocardium to initiate contraction in a specific set of time. Now, when the SA node generates action potentials, The electrical impulses travel throughout the conducting system to have the heart contract in a controlled manner, so that the blood filling in the atria and the ventricles work in harmony. And this can work only if the velocity of the impulse conduction differ based upon the location of the cardiomyocytes. So within the conducting system, specifically in the atria, the transmission speed is about 1 meter per second. So almost immediately after the SA node generates an impulse, it is transmitted to all atrial pacemaker cells. When the impulse reaches the AV node, it slows down to about 0.1 meters per second, which is literally the slowest speed of impulse transmission throughout the heart. Now, what's the significance of this? Because it has significance. One of the significance allowing for the AV node to delay the impulse before it sends the impulse down through the interventricular septum to the bundle of His is because it wants to give time for the atria to contract before the ventricle contracts. I can't express how important this is. Because of this delay, it gives the atria enough adequate time to contract and push the blood into the ventricles. Because if the AV node didn't conduct the impulses slower, it would have depolarized the myocardium in the ventricles while the atria are trying to empty their blood into the ventricles. If that's the case, then as the ventricles are getting depolarized, they might start contracting at the same time as the atria are contracting. That's counterintuitive. We don't want that. We want to allow for the atria to squeeze all the blood into the ventricles, then let the ventricles attain the blood, then push it out towards the aorta and the pulmonary circulation. Now, why is the conducting system slower here? We know the purpose. It gives time for the atria to contract before the ventricles contract. But there are two microscopic reasons why. These nodal cells are riddled with a ton of gap junctions, which are basically channels which allow the ions to pass from cell to cell. However, the AV node, which consists of a bundle for those nodal cells, it has a lot less of these gap junctions than these other nodal cells. So a lot less gap junctions, which means a lot less ions can flow from cell to cell. That decreases the actual speed at which it's moving. So we say, because of this, there's a greater resistance of conduction of excitatory ions from one conducting fibers to the next. That's one reason. That's why it's a little bit slower. Another one is because the nodal cells that are in the AV junction are smaller. They have a lower diameter. And if you know a little bit about the conduction, we know that the larger diameter of the structure, the faster the velocity of that conduction is going to move. So the smaller the diameter, the slower the conduction speed. Okay, so again, the transmission speed in the atria is about 1 meter per second. It reaches the AV node, slows down to 0.1 meters per second. Then, when the impulses finally reach the ventricles, the speed of conduction varies between 1 to 4 meters per second. It's so fast, almost instantly, all the contractile myocardium will contract at the same time. Now, keep this in mind. The working myocardium also has gap junctions, which means when they're depolarized, they can conduct the impulse in a speed of around 0.3 to 0.5 meters per second. So in case the conducting system is damaged as a result of infarction or surgical error, then these working myocardial cells can transmit the impulses as well, but in a slower rate, which can be problematic because some cells then after the damage will contract, meanwhile the cells before the damage are already starting to relax. And here we see how this plays out in fraction of a second after initial depolarization of the SA node, showing how many seconds it takes before the different parts of the heart receive the signals. Now, there are just two things here that I want to highlight before we go further and talk about the other cardiomyocytes. Notice the delay in seconds between the atria and the ventricles. And I want to ask you again, why is there a delay here? Because of the slow conduction of the AV node. The other thing I want to mention here, and this is so important to know, is that the AV bundle has a special characteristic in that it can only do a one-way conduction, allowing only forward conduction from the atria to the ventricles. This prevents something called re-entry of the cardiac impulses, meaning it prevents the impulses from going from the ventricles back into the atria. So I want to ask you now, why can't the impulses just travel from the atria down to the ventricles from the right side or the left side? Why does it have to go through the AV node and the AV bundle? This is because everywhere except at the AV bundle, the atrial muscle is separated from the ventricular muscle by a continuous fibrous barrier, as you see here. This barrier normally acts as an insulator to prevent passage of the cardiac impulse between the atrial and the ventricular muscle through any other route besides forward conduction through the AV bundle itself. So when you start studying the impulse diseases in the heart, you can come across an instance where there's an abnormal muscle bridge that penetrates the fibrous barrier elsewhere besides the AV bundle. If that happens, what do you think is going to happen now? The cardiac impulse can re-enter the atria from the ventricles and cause a serious cardiac arrhythmia. Alright, that is the pacemaker cells. The second type of cells are the endocrine cardiomyocytes. These endocrine cells in the heart are located both in the atria and the ventricles. These special cells contain secretory granules filled with hormones that are secreted out in response to stretch of the cardiomyocytes due to an increased blood volume. And they are atrial natriuretic peptide, primarily from the atria, and the B-type natriuretic peptide, secreted primarily from the ventricular cardiomyocytes. And since they are secreted in response to stretch, their primary function is to try to decrease the blood volume by decreasing the sodium and water reabsorption from the kidneys to promote vasodilation. We will talk about these in a little more detail in the last video of this series, where we will cover the different ways the heart pumping is regulated. The third type of cardiomyocytes are the contractile cells. So these are the ones that consist of the actual contractile proteins. So they consist of the actin and myosin and troponin and tropomyosin. They're also special because they contain something called sarcoplasmic reticulum. I will show you in a second. Now, these contractile cardiomyocytes are arranged in a specific manner, and they have arms extending to the neighboring cell, connecting them through something called intercalated disc, which is essentially made up of gap junctions and desmosomes, making it easier for signals to pass on to the next cell. And because the cardiomyocytes have these gap junctions, we say that the cardiomyocytes work as a functional syncytium, which basically means that it consists of a group of cells that function as a single unit, while still maintaining their individual cellular role. Alright, now, let's take one pacemaker and one contractile cell and draw an outline of each cell just like this. So we're looking at two different types of cells, a nodal cell and a contractile cell. And we're going to see how these two cells are communicating and what's all these ion channels and stuff. And so let's draw a gap junction between these cells. And we will use these two graphs to illustrate the voltage change and the phases of each functional cell. Now, there's a lot of graphs when it comes to cardiac physiology, but they make so much sense once you actually understand what happens at each phase. In each graph, I've denoted one line with the longer dots and one line with shorter dots. The one with longer dots means resting membrane potential, which essentially means that each cell don't normally go below this level in respect to the voltage change. And the shorter dotted lines represent threshold potential, meaning when the voltage inside the cell reaches the voltage of the threshold potential, it's going to activate a certain function. Now, pacemaker cells don't really have a stable resting membrane potential. They're never really at rest, if it makes sense. It's kind of funny. It's funny. The pacemaker cells has funny sodium channels. I'm not even kidding. I have no idea why they're called funny sodium channels. But these channels that are within the wall of the nodal cell are very leaky, and they allow for a little bit of sodium to leak into the cell very, very slowly. And because they're leaky, the pacemaker cells don't really have any stable resting membrane potential. So the lowest point at which the voltage can go to is around -60 millivolts before the voltage turns and starts to go towards the positive side again due to the slow sodium influx. When the membrane potential reaches around -55 millivolts, T-type calcium channels starts to open, and we now start getting calcium influx as well. As these sodium and calcium ions starts coming into the cell, look what happens. We start hitting the threshold potential. Now that we have hit the threshold, the long-lasting calcium channels open up. These L-type calcium channels blast open, and we get a huge influx of calcium, depolarizing the cell up to around 30 millivolts. These voltage numbers can vary a little bit, so you'll often see a slight number differences in different sources. But now, what happens now? Now the cell is depolarized. We've depolarized the cell. It didn't require any nervous system functioning. Isn't that beautiful? What happens now is that we have accumulated all of these cations in the pacemaker cell. Once it's depolarized, it will shoot these cations through the gap junctions into the next cell. The contractile cardiomyocyte is usually at rest at around -85 millivolts, so the resting membrane potential of the contractile myocardium is around -85 millivolts. When the cations flows in from the pacemaker cell, it starts to depolarize. It goes up and hits the threshold potential of right around -60 millivolts. This threshold potential will now trigger the voltage-gated sodium channels to open. While this is happening, if we go back to the pacemaker cells, the L-type calcium channels will close and potassium channels starts opening up, and we will get an efflux of potassium, which triggers repolarization. So potassium ion starts going out of the cell, which brings the membrane potential all the way back to -60 millivolts. Alright, let's go back to the contractile myocardium. When the threshold potential reaches -60 millivolts, voltage-gated sodium channels open up and we get a huge influx of sodium. So the membrane potential shoots up to about +40 millivolts. Again, these numbers can vary a little bit, but the sodium influx will trigger a positive charge throughout the cell membrane. And when it reaches about 40 millivolts, potassium channel starts opening up, which brings potassium ions out of the cell. At the same time, these voltage-gated sodium channels are now closing. So since we have potassium ions going out and no influx of sodium, the membrane potential of the working myocardium starts going down or repolarize. Now, the contractile cells have something called T-tubules, which are packed with extracellular calcium. These T-tubules are equipped with something called dihydropyridine receptors, which are a form of L-type calcium channels. When they receive an impulse, these channels will open up and cause an influx of calcium. Now, within the contractile cardiomyocyte, you will find sarcoplasmic reticulum, which contain a lot of calcium. So the sarcoplasmic reticulum has something called ryanodine receptors on it. And we say there's a voltage-gated coupling between the dihydropyridine receptor and the ryanodine receptor, in that when the calcium flows in, it binds to the ryanodine receptor, activating it and causing it to release a whole lot of calcium into the intracellular fluid. So two things happen when the dihydropyridine receptors are activated. It causes the influx of calcium necessary for contraction and also necessary for activation of ryanodine receptors. Now we got a high amount of calcium ions in the cytoplasm. Now we want to contract the cardiomyocyte. Inside of the cell, we got something called troponin complex, which is a complex of 3 regulatory proteins called troponin T, troponin I, and troponin C. Troponin T is a protein that binds to tropomyosin to help with the positioning. Troponin I is a protein that binds to actin. And because it binds to actin, it prevents the myosin from binding to the actin in a relaxed state. Troponin C is a calcium-sensitive protein that has 4 calcium-binding hands, and it also holds hands with troponin I. So when troponin C is activated, it changes the form of troponin I. The way I remember it is, remember tic-tac for this one. So what happens is, when calcium binds to troponin C, it causes it to change its form, which leads to dislocation of troponin I. And when that happens, tropomyosin leaves the binding site for myosin unacting, leading to contraction of the muscle. So the heart can squeeze the blood out to the systemic circulation. So the letter I in troponin I is given due to its inhibitory character, and is a really useful marker in the laboratory diagnosis of cardiac muscle damage. Now, while all of this is happening, the cell voltage is neither going to increase or decrease, because the rate at which the calcium is flowing in is approximately the same as the rate of which potassium is flowing out. So all of this happens during a plateau phase. Now we want to remove the calcium from the intracellular space, because if it's there for a long time, it's just going to keep binding and contracting the muscle cell, and the heart will eventually become weak if it doesn't rest. So we need to get the calcium into the sarcoplasmic reticulum and out into the extracellular space. It does that with the help of calcium pumps. These calcium pumps are located in 2 places: in the cell membrane of the wall of the sarcoplasmic reticulum, Another name for them is SERCA, or sarcoplasmic reticulum calcium ATPase, and PMCA, or plasma membrane calcium ATPase. And they're primarily going to use ATP to pump calcium into the sarcoplasmic reticulum and out to the extracellular space. Now, SERCA has a phospholamban attached to it, which is going to inhibit the pump. The SERCA pump is still somewhat active, but its efficacy is reduced due to the inhibitory effects of the unphosphorylated phospholamban. Only when the sympathetic nervous system gets activated, it will phosphorylate and remove the phospholamban inhibition on the SERCA, and a lot of calcium will be pumped into the sarcoplasmic reticulum. But that doesn't happen in a basal condition without sympathetic stimulation. We will talk about this in detail when we go through the regulation of the heart pumping in a separate video. But a little bit of calcium is going to flow into the sarcoplasmic reticulum because the SERCA pump is still somewhat active. Alright, what else? How do we remove the calcium? In the wall of the myocardium, we will find something called sodium-calcium exchanger, which uses sodium gradient into the cell to transport calcium out of the cell. This is called secondary active transport, this mechanism, which depends on the sodium-potassium pump activity. Now imagine if the sodium-potassium pump keeps pumping sodium ions out of the cell, it will decrease the concentration of sodium in the cytoplasm. The sodium can then easily be transported into the cell at the same time calcium is transported out. It's a really cool mechanism. And there's an abundance of these sodium-calcium exchangers along the cell membrane, especially at the T-tubule area. Now, as calcium is going out and potassium is still keep getting pumped out, we will now repolarize the cell all the way back to its resting membrane potential, which is around negative 85 millivolts. While all of this is happening, guess who's working? The funny sodium channels back here. And watch how the pacemaker cells don't have any resting membrane potential because of that. Also, while the depolarization is happening, the contractile cardiomyocytes can send its impulses further to the next cell when it's in the depolarized state. So that's really it. That's how the heart is able to contract and relax without any external stimulation. Alright, awesome. Now, let's take a closer look at these two graphs and divide these graphs into phases so that it makes so much more sense to understand them. The pacemaker cells can be divided into three phases. First one is the slow diastolic repolarization phase. Remember, during the slow depolarization, we got funny sodium channels pumping in sodium as well as transient calcium channels pumping in calcium. Then we got a fast depolarization after the cell hits threshold potential, where the L-type calcium channels open. When the depolarization is done, we got repolarization, which pumps potassium ions out until it reaches around negative 60 millivolts again, where the funny sodium channels start working and the cycle continues. For the contractile myocardium, we can divide it using numbers from 0 to 4. Phase 0 is depolarization or rapid depolarization, which is due to the sodium influx. So when an action potential arrives from the neighboring cell through gap junctions, the voltage within the cell increases slightly, and when this increased voltage reaches a threshold potential of approximately negative 60 millivolts, it causes the sodium channels to open, and this produces a large influx of sodium into the cell, rapidly increasing the voltage further to around plus 40 millivolts. All of this is happening in this phase. Next, phase 1 is the initial fast repolarization, where the fast sodium channels close and potassium ions open. Now we're losing potassium, so we're only losing cations. Phase 2 is the plateau phase, where we are now getting calcium influx, which is electrically balanced with potassium efflux. So we're losing potassium and gaining calcium at a rate of which the electrical gradient is kept constant. And remember, in this phase, the cell is contracting. And after contraction, we want to further repolarize the cell. So phase 3 is the end fast repolarization, where L-type calcium channels are closed, and we get a further potassium efflux, as well as removing calcium from the intracellular space back into the sarcoplasmic reticulum and into the extracellular space. And now we're at phase 4, which is the resting membrane potential of approximately negative 85 millivolts as a result of a constant outwards movement of potassium. So that's basically how we divide these graphs into phases. Now, the next thing I want to talk about, and this is really important, is something we call refractory periods, which basically just means a period of time when the contractile myocardium is unable to contract. So in the y-axis, 100% means that the cell is 100% able to respond to the next stimulus given, while 0% means it's not going to respond to the next stimulus, no matter how much you try to stimulate it. Now, the excitability of the contractile myocardium depends on the voltage-gated sodium channels. And if you zoom in on the voltage-gated sodium channel, you will see that it has two gates. It has an extracellular activation gate, which can open due to a stimulation. And within the cell, there's an inactivation gate, which is not opened by a stimulus, but it opens if the membrane potential becomes lower than -40 millivolts. Now, if we look at the phase with the resting membrane potential, the activation gate is closed while the inactivation gate is open. Can we open this gate if we stimulate it? Absolutely. So in this stage, we say the cell is 100% excitable. If we apply threshold or suprathreshold stimuli, the activation gate can respond to that stimulus and open. Now, during the depolarization, both the activation and the inactivation gates are open. So there's a sodium influx. If you stimulate the cell now at this stage, will the cell respond? Nope. It's already responding to the previous stimulus. So the cell is 0% excitable. And because of that, we call this stage absolute refractory period. Now, once it's at the top, the inactivation gate is closed. It starts closing gradually once you get above -40 millivolts. And since we're now above -40 millivolts, the inactivation gate is closed. And the activation gate is still open. Can we excite this channel at this stage? Absolutely not. The inactivation gate doesn't respond to stimulus. So we're still on the absolute refractory period. When the membrane potential reaches about -40 millivolts, then the inactivation gate of the voltage-gated channels starts opening, and the activation gates starts closing. And since it's starting to open, the gate becomes gradually excitable, going from 0% gradually up to 100% as the gate is opening. This phase is called relative refractory period, so it can theoretically react to a stimulus at this point. After the relative refractory period, we go back to having the inactivation gates open and the activation gate closed, ready to receive another stimulus. The refractory periods make so much more sense when you understand the concept around these gates on the voltage-gated sodium channels. Now, because the myocardium has these long-lasting calcium channels which prolong the time of repolarization, the absolute refractory period in the myocardium will last about 0.25 to 0.3 seconds in the ventricles, while in the atria it is halved, approximately 0.15 seconds. The relative refractory phases are approximately half the absolute refractory phase, so about 0.15 seconds in the ventricles and 0.7 seconds in the atria. Sometimes, and this is pure theory, to categorize the excitability, we have a term called effective refractory period, which is basically the whole absolute refractory period and also the beginning part of the relative refractory period. Because in the absolute refractory period, you just cannot generate an impulse here. It won't react to stimulus at all. While in the beginning part of the relative refractory period, the cells are so low excitable that they just can't really respond to the impulse generated in the previous working myocardial cell. Alright, awesome. Now let's do the last segment of this video. The cardiomyocytes have certain properties that are special. The first one is that the cardiomyocyte has the intrinsic ability to depolarize itself and cause a contraction. This is called automaticity. Now I want to ask you, why are the cells able to have this property? Well, it's because of the funny sodium channels. Awesome. Next is that cardiomyocytes contract following the all or none law, meaning if the contraction happens, it's always maximal. If it doesn't happen, then it doesn't happen at all. So for example, in skeletal muscles, if you gradually give it stronger contraction, you will see that the force of contraction follows the strength of the stimulus. And the force will gradually increase until all the motor units have responded to the stimulus. In the heart, however, it won't respond to a subthreshold stimuli, but when it receives a threshold stimuli, it will give a full contraction all the time. And remember, this is primarily due to the electrical synapses between the cells, which makes the cell function as a syncytium. The third property of the cardiac muscles are the long refractory periods. Remember, we said earlier that the absolute refractory period is significantly longer than in other types of muscles, lasting around 0.25 to 0.3 seconds because of the plateau phase. I can't express how important this is to our heart. One good thing about it is that it prevents tetanus, meaning the long absolute refractory period ensures that the cardiac muscle cells cannot be re-excited until the previous contraction is nearly complete. This prevents the possibility of something called tetanic contractions. And what happens if the heart could undergo tetanic contractions under normal conditions? It would prevent the heart chambers from filling with enough blood between the beats. These refractory periods can also help maintain a regular heart rhythm by preventing premature contractions, called extrasystole and re-entrant arrhythmias. We will talk more about this when we get to arrhythmias, but this stability is essential for consistent and effective cardiac output. Let's visualize it just for a second. Here we see a continuous stimulation with continuous depolarization and repolarization of the heart muscle. Within this area is the absolute refractory period, meaning if the heart would get an artificial stimulus within this period, nothing will happen. But if we give an artificial stimulus to the heart during the last 2/3 of the diastole, we can trigger additional systole called extrasystole, which is followed by a compensatory pause, which is longer than the pause between the regular heart contractions. And why is it longer? It's longer because the heart has now skipped one normal contraction, because we received the signal during the refractory period of the extrasystolic beat. Now, the heart has to wait for the next normal stimulus to trigger the next normal contraction. This pause is so important because it allows the heart to fill up before it contracts again. Alright, so that was everything I had for the cardiac muscle. We covered the different cell types, the action potentials of the pacemaker cells, the action potentials of the contractile myocardium, as well as the refractory periods and the different properties of the cardiac muscle. The next video is going to be about the cardiac cycle. Thank you all for watching. If you found this information helpful and want a little extra practice on cardiomyocytes, I've created a quick follow-up video with quizzes and questions. These resources are available exclusively for channel members, and I've kept the membership fee as low as possible to support the channel's growth. Your support means so much to me. Consider becoming a channel member to access these additional resources and help me create more educational content like this. Just click the join button below to get started. Thank you again for watching, and I hope this was helpful. See you in the next video. Peace.